Welcome, ladies and gentlemen, to our international webcast today. The topic is full endoscopic possibilities in cases of central spinal canal stenosis. We welcome our international guest to our headquarters here in Germany. It's afternoon in Germany, and we are connected to Asia, we are connected to Germany, and right now it's quite late in Asia, and we are pleased and honored that we can do this webcast today with our international faculty, which is Dr. Arun Bhanot from India. It's Dr. Veerapan from Bangkok, Thailand, and it's Christoph Siepe from Munich, Germany. Hello, together. We are now connected live to all that places. We talked already about the temperatures, but would you mind to do a short introduction for our international guest? We start probably with Dr. Bhanot. Hello to India. Can you hear me?
Yes, I can hear you. So my name is Arun Bhanot, and I am a spine surgeon working in New Delhi, India. My major interest in spine is minimally invasive and full endoscopic spine surgery. I've been doing it for about 12 years now. And I've been trained at Korea at Hergate with Dr. Richard and Dr. Tom. And have been had the pleasure to interact with Dr. Sipe and Dr. Veerapan as well. Both of them are doing excellent work and gained a lot from interaction with the faculty.
Thank you very much. Dr. Veerapan, would you mind to say some words to our guest?
I'm Veerapan from Bangkok. I'm a neurosurgeon. I start doing endoscopic surgery since 2007, around 13 years, of course, by Professor Rutten and Professor Com. And then we have been working together to set up the workshop both in Germany and in Bangkok for the past 11 years. Thank you.
Christoph Siepe from Munich. Hello to Munich. Not that far from our place.
Thank you very much for the invitation. My name is Christoph Siepe. I'm here in Munich. I work in the lateral spine center. We do all kinds of surgeries, from the large deformity surgery and reconstructive surgeries, all the way to minimally invasive procedures, thoracoscopic procedures, minimally invasive anterior approaches to the thoracic and lumbar spine. And I've basically grown up with a microscope. I've done really thousands of surgeries with a microscope, and for many, many years now, I've made the transition to going endoscopic, and I'm now almost exclusively, or I would say at least the vast majority of the compression procedures that I'm doing are now endoscopically. So thank you for the invitation, and I'm happy to share my experiences doing this transition. And if you have any questions, then don't hesitate to raise any questions, and I will try to answer at the end of my presentation.
Thank you very much. So we are very pleased that you all share your experience with our international guests today. And to our international guests, whenever you have questions, please use the chat function in our YouTube channel, so you can type in your questions directly. And we will answer that in between the lectures as soon as possible. And you will we will make sure that no questions will be open at the end. So whenever you have this, please send it to us. You can also use our email channel, education@rivospine.com. We will also check this, and we are looking forward to your questions today. Okay, then let's start with our first topic. Today, the general topic is spinal canal stenosis, and we try to give you an overview about the full endoscopic treatment. And we will start with the foraminal stenosis and the lecture of Dr. Arun Bhanot from India.
Good afternoon, everyone. My name is Arun Bhanot.
And today I would be talking about the role of full endoscopic spine surgery to treat the pathologies of foraminal and extraforaminal stenosis. Foraminal lesions that lead to radiculopathy due to compression of the exiting nerve root can be either due to facet hypertrophy or thickened ligamentum flavum or thickened foraminal ligament, or along with the shoulder osteophytes and sometimes a foraminal disc herniations. These lesions can be present in isolation or in various combinations, but ultimately leading to compression or narrowing of the foraminal zone, thus leading to compression of the exiting nerve root and causing radiculopathy in the distribution of that nerve. As degeneration happens and age advances, we know that the disc height is lost, and due to the telescoping of the disc height, we can witness the presence of narrowing of the foraminal dimensions as seen in simple x-rays as well. Foraminal stenosis has been classified based on MRI observations, especially of the parasagittal sections, and it is classified from grade 0 to 3. Grade 0 is essentially normal and does not represent stenosis but a normal representation of the foraminal anatomy, and grade 1 mild, 2 moderate, and grade 3 is severe foraminal stenosis. We will see what that means. Grade 1 means 1A means that perineal fat is obliterated in the transverse direction, thus leading to narrowing of the superior foraminal width. Though the dimensions of the foramen are narrowed, but there is no morphologic change in the exiting nerve root. Similarly, in grade 1B, the perineal fat obliteration is more noticed in the vertical direction, thus leading to narrowing of the foraminal height, but still there is no morphologic change in the nerve root, which is seen in these two schematic drawings as well as in the example MRI pictures. In the grade 2 moderate foraminal stenosis, the perineal fat obliteration is seen from all four directions, but despite this narrowing, there is still no morphologic change noted in the nerve root. So, patients with suffering from grade 1 and 2 mild to moderate foraminal stenosis may have transient radicular symptoms depending upon the activation of that nerve root from various time to time, but they may not have constant presence of symptoms because the morphology of the nerve root is still intact. But as we move to grade 3 severe foraminal stenosis, as we notice in the schematic here as well as in the MRI picture, there is a severe perineal fat obliteration from all four directions, but in addition we can see that there is a morphologic change in the nerve root. Such patients are likely to have constant discomfort in the lower back or one side or buttock, and sometimes all along the distribution of the that nerve, leading to constant radicular symptoms and sometimes severe restriction in their day-to-day life due to the claudicant nature restricting their walking. The foraminal narrowing can be there because of the osteophytes arising from the vertebral body or from the facet joint. So that means from anterior and posterior, and sometimes from both the sides. And we, while assessing these patients, we have to take into account these twin pathologies, especially in the very elderly population. This is a anatomic picture taken from Dr. Roshnig's work on cadavers that shows that in the degenerative spine, the telescoping of the facet, the ascending facet, can push the nerve root superiorly along the posterior margin of the vertebral body as well as the undersurface of the pedicle. And this is an animated picture showing how this telescoping will lead to pushing of the exiting nerve root against these two bony margins, thus causing compression of the exiting nerve root. So these changes are especially noted in the elderly patients who develop degenerative scoliosis, and they are most likely to suffer from such lesions. And we all know that these are the patients who are very vulnerable because of their comorbid conditions to undergo any major big surgeries. Now, what is foraminoplasty? The foraminoplasty actually means that you widen the intervertebral foramen to address compressive pathologies that lie within the foraminal or the extraforaminal zones. There is another term that is used called as foraminotomy, which is sometimes used synonymously, though some authors prefer to differentiate between the two. But the essential thing is that we change the dimensions of the foramen. Now, foraminotomy can be used to widen the foramen to access pathologies that may lie in the epidural space and spinal canal as well. Like, for example, this picture here shows how the foramen has been widened by drilling the undersurface of the ascending facet in a lower thoracic spine to gain access to a paracentral herniation in the lower dorsal spine. So, you can see the comparative post-op CT scan, how the foramen has been widened. Foraminoplasty can be done by using various hand and mechanical instruments like chisels and trephines, which can be used to undercut the undersurface of the ascending facet under fluoroscopic control. And this is how it used to be done, and a lot of people still do it. Some people under fluoroscopic control, and some people have started using these instruments under navigation control as well. But personally, I prefer to do my foraminoplasties under endoscopic visualization using the endoscopic drills, which gives me more confidence to do my work protecting the nerve root. Cannula position and manipulation for such foraminoplasty positions is just like we do for extraforaminal herniation. This is a small animated video that I recorded for making it understand. So like for extraforaminal herniation, we dock the cannula at the facet pedicle junction first as a bony landmark, and then clear the undersurface of the facet, and then we rotate the beveled cannula to look for the pathology lying in the foramen. For example, in this case, the blue thing is the herniated extraforaminal herniation. This is the example of a 78 years old male who was suffering from disabling left leg radicular pain that was leading to severe restriction in his walking and day-to-day activities for a few months, and he is a cancer survivor. So if you look carefully, you can see a large disc osteophyte complex at L5S1 starting right at the edge of the foramen and going along the extraforaminal region where the L5 root is traveling, leading to the left leg radicular symptoms. So in this case, we initially gave him a diagnostic L5 root block at this region, in the extraforaminal region, and he responded well to the block for a few days, and then his symptoms recurred as was expected because it was a bony osteophyte, so we did not expect a long-term resolution. But after the block, we recommended a full endoscopic decompression. We did it under general anesthesia and prefer to do the foraminal decompressions under general anesthesia as compared to local anesthesia, because you have to handle the exiting nerve root which is already inflamed by the compression, and you may have to drill along protecting the nerve root by retracting it a little bit. So it may be difficult to work with in such a manner with the awake patient. So I prefer to do it under general anesthesia for such people as and when possible. So as already mentioned, the working cannula is docked on the lateral surface of the ascending facet. This is the part where we dock the cannula and then we drill along the facet to reach the exiting nerve root. This is a small video. Though you can see the needle has been docked on the lateral edge and the beveled cannula has been introduced. So this is the initial endoscopic visualization showing the muscle and the deep fascia covering the lateral surface of the ascending facet, which is coagulated first to allow blood-free visualization, and then the soft tissue is removed to denude the lateral surface of the ascending facet. Now the endoscopic drill is brought in to drill. So you start drilling from the caudal to the cranial side to protect your exiting nerve root as you advance closer to the foraminal region. And as you reach deeper from drilling from posterior to anterior edge of the ascending facet, and once you are close to the anterior edge, then you start drilling with the end protection side cutting bar here, just like here, so that you may not accidentally injure or cause pressure on the exiting nerve root. So once the anterior edge is sufficiently cleared, we would start visualizing the intertransverse ligament here. Like now the intertransverse ligament has been exposed, which is lifted and then removed bit by bit with the
endoscopic Garrison punch here as shown here. And as we start removing the intertarsus ligament, we can start having a glimpse of the exiting nerve root, which is covered with this fat. And once the fat is gently lifted, we can start seeing the exiting nerve root. Now the fat is cleared to visualize the exiting nerve root nicely. And once the exiting nerve root is completely visualized, then we expose the undersurface, we expose the osteophyte which was pushing on the exiting nerve root from below. So once it is cleared, we bring in the endoscopic drill again. Now it's a diamond burr which we use to drill for the osteophyte. The osteophyte is gradually thinned, and we can also use this deflecting tip endoscopic burr to keep it away from the side of the exiting nerve root, to keep it protected, and still can drill that part. Now the osteophyte has been thinned, and now the thinned osteophyte is being removed completely. And once we remove, we can see that the exiting nerve root is fully decompressed right from its superior edge to the whole width of the exiting nerve root, and we can no longer see the osteophyte which was at the 3 o'clock position, between 2 to 4 o'clock position. This is the postoperative CT scan showing well decompressed osteophyte, and along with the drilled lateral surface of the facet, and the exiting nerve root has been given adequate space to travel. So important tips for foraminal decompression: one should dock the cannula on or close to the facet. There is no need to introduce the cannula into the disc space. I prefer to use beveled working cannula for better visualization and understanding of anatomical structures. Another benefit the beveled working cannula provides is that if you have to advance the cannula into the foramen, and you have to drill some part protecting the exiting nerve root, you can just rotate the bevel and protect the exiting nerve root while drilling, just like we do it for interlaminar endoscopic technique. We use the bevel or flange of the cannula to protect the nerve root. One should start the decompression from caudal to cranial side to avoid damaging the exiting nerve root, because we do not know exactly when you can come across the nerve root, though it is related to bony structures. So it is safe to drill from caudal to cranial side to avoid damaging the exiting nerve root. So the benefits of endoscopic foraminal decompression: it's a easy and simple technique, and because you do not do any major cutting of the normal structures, so the trauma to the surrounding tissues is reduced because of your focused and targeted approach. As you do not do any big incision surgeries, of course, the operation related back pain is also not seen much, and you can avoid bigger and more morbid procedures in a elderly and delicate population which are already suffering from multiple diseases. And naturally you avoid using any implants, you avoid longer stay in hospital, so it's a cost-effective surgery. But the biggest benefit is that you are able to have an excellent unmatched visualization of the anatomical structures and do your decompression. Thank you.
So welcome back, dear guests, and thank you very much, Dr. Arun Barnot from India, for this nice presentation. It was a great presentation, and thank you for sharing your experience with us. So far, we didn't receive questions yet, so to all guests, if you have any questions, please use the chat function in YouTube or send us an email via education@rivospine.com. Dr. Arun Barnot will be ready for answering all the questions within the next time. Now we continue with the next lecture about lateral recess stenosis and Dr. Veerapan, and we start directly now.
Hello everyone, I'm Veerapan Kunsongtham from Bangkok, Thailand. Today I'm going to talk about a surgical technique for the interlaminar endoscopic discectomy. As everyone knows, the endoscopic spine surgery was started with a transforaminal approach more than 20 years ago. And over the years, the indication for the transforaminal remained. But in the past 15 years, when Professor Sebastian Rutten introduced the interlaminar approach to the society, because he faced the difficulty and the limitation from the transforaminal approach. Since then, the indication for the endoscopic surgery has been wide enough to treat many different pathologies. So why would we need the interlaminar approach? In the case of the high-grade migration, beyond the lower rim of the upper pedicle and the mid-level of the lower pedicle, or in the L5S1 situation where the iliac crest is along the way obstruct the transforaminal approach and force the approach to be in the foramen instead of in the spinal canal. You may see from the diagram this the anatomy of the lower level of the lumbar spine favor the interlaminar approach because the interlaminar space is the biggest at L5S1 and gets smaller once you go the higher level, and the iliac crest is obstruct the way with the transforaminal. So you would consider more interlaminar approach with the L5S1 and L45, and then when you go up, consider more with the transforaminal approach. This is the general rule. So we have to think about both approach, which one is less invasive and easier to get to the pathology. And when we talk about the interlaminar approach, the anatomy that you see from the endoscopic view is more familiar when compared with the microscopic view. That means we are looking from the back, and we are looking from medial to lateral. Remember that this one is a transmuscular approach. That means you don't have the limitation of the movement compared to the transforaminal. But on the other hand, you have more difficulty to handle the scope, which I will explain later. And this is the approach that you are going directly into the spinal canal through the ligamentum flavum, and you can avoid the complication of the exiting nerve injury compared to the transforaminal approach. And once you open the ligamentum flavum, you enter the spinal canal, and you can use the tip of the cannula as a retractor to retract the nerve. And one thing that you may want to pay attention to the interlaminar approach is the anatomy of the spinal canal itself, which is widest at L5S1, and it becomes more narrow once you go up the higher level. And another fact is the size of the facet joint. It's more flat at L5S1 and getting higher at the upper level. And if you have the facet joint hypertrophy, that makes the spinal canal become more narrow and become deeper, because the facet joint itself acts like a big mountain. So you may have to drill to open up to smaller the facet joint at the higher level and make the spinal canal wider at the higher level. And every case that you want to start with any surgery, you have to study in detail, especially the MRI findings, the relationship between the disc herniation and the thecal sac, exiting nerve, traversing nerve, in order to plan the approach. And this is the setting in the operating theater. We want to widen up the interlaminar window by flexing the bed, the surgical bed, and then you have to slide the bed to have free space for the fluoroscope. And we do it under the fluoroscope, the first X-ray in the AP. So you have to be sure that you have the sharpest edge of the both lamina, and then you have the interlaminar window. You mark the entry point a little bit near midline because you want to avoid the interspinous ligament. You make a cut, and you want to cut not too big the skin, because if you cut the skin too big, the scope, the cannula become very loose, so you lose the fulcrum at the skin if you cut the incision too big. So the cannula can run down or run up easily. So make the skin incision small, just enough to pass the
dilator and cannula inside. And then under the AP control, you put the dilator. So in the window, so the AP control is just to make sure that you are not too much outside the window, not too high, not too low. And the depth you cannot see from the AP. You have to turn to the lateral. So you turn to the lateral to see the depth. So when you cut, you want to cut the skin and the fascia at the same time. So if you don't cut the fascia, it's very difficult for the blunt tip dilator to enter. So you have to cut the fascia as well. And you confirm the depth of the system under the lateral X-ray. And then you put the endoscope. Compared to the transforaminal, the blind shot under the X-ray control is all the time outside the spinal canal, that's in the muscles, and then you face the ligamentum flavum, you put the endoscope in. Compared to the transforaminal, that all the blind shot under X-ray happen through the foramen and to the thecal sac beside the exiting nerve. That is more demanding for the transforaminal compared to the interlaminar. And the handling of the scope is the most important thing of the interlaminar approach. So for me, the dominant hand is the hand that you hold the system, and you have to make a lot of motion like the joystick movement, and then you have to hold the scope, and then you use the little finger and sometimes the ring finger to control the cannula, to rotate the cannula, and you have to control the rotation of the scope to look around, zoom in, zoom out motion. These are the left hand control. If you don't have enough left hand control, the endoscope is like the microscope, no benefit. So this is a setting in the operating theater. So basically it's the same anatomy of the micro technique plus the benefit of the endoscopic view with the left hand control. So I will step by step with the case illustration. So this is the case come with a severe back and right leg pain for 5 months, and this patient underwent a lot of physical therapy and then the injection, and he failed to improve himself. So this is the MRI study. This is the video. Okay, so normally with the MRI is our regimen to have the whole spine MRI. So you can count the level from C1, and we have the thin slice, 1 millimeter. So you see this is the paracentral herniation with downward migration, compressing the right R5 nerve. So we're gonna do the right interlaminar approach from the right side. So before we go in from this patient, we see that is a downward migration. So I think I decide to make a drilling in order to expose to the free fragment and to widen up the spinal canal. Before we make a drilling, we have to prepare the soft tissue. We have to expose the upper lamina, lower lamina, the descending facet down to the tip, and then we have to cut some part of the superficial layer of the ligament. This is the soft tissue preparation. So we approach from the right side of L45. After we get to the ligament, so we cut the superficial layer of the ligamentum flavum. As you may see, we identify the tip of the descending, and then we identify the descending facet up to the upper lamina. You see, you can lower the scope to have a zoom effect, and we cut the soft tissue until you see the upper lamina. In the case, I cut some part of the facet joint capsule and remove some tissue to identify the upper lamina. And then you want to see the upper lamina, the descending facet, including the tip, and you see already the part of the ascending facet before you start the drilling. And then you can start the drilling from the tip of the descending facet and up to the upper lamina, and it has to be higher than the tip of the ascending facet. Here, go in again. So ligamentum flavum, the tip of the descending facet and some part of the ascending. So only the side of the drill that cut. So you place the tip on the ascending facet or on the ligamentum flavum and use the side to cut. And you have to rotate the scope and lower down the scope to see the tip of the drill all the time. It's very powerful yet very dangerous. So you want to cut only the bone. Okay, use the side to rub and use the left hand to move the system all the time, like you are rubbing on the bone. And the right hand, you can rotate the drill back and forth. So the important thing is you want the smooth surface on the bone, so it makes you easier to stop the bleeding on the bone. So the smooth surface drilling is very important. So you have to move the system all the time. We start to see the part of the ascending facet at the tip of the ascending facet. So you want to remove more and higher than the ascending facet. Okay, so the tip of the instrument, we see it all the time. The tip is on the ligament and on the ascending facet. Sometimes you want to remove more the superficial part of the facet joint in order to go deeper. Yeah, so you see I rotate the drill. And after you expose the tip of the ascending facet, and you will start the drilling from the tip of the ascending facet. Here, this is the ascending facet. So drill from the tip down. And every time you want to go deeper, you have to stop the drilling and you push the drill deep down and use as a dissector to dissect the ligament from the bone. But don't drill and push it down at the same time, because it can be sucked down to the spinal canal. And underneath the ascending facet is a traversing nerve. So and the ligament become very thin when you approach to the lower lamina. So you have to be very careful. Sometimes you can leave the thin layer and cut with a correction later. And I demonstrate, if you don't rotate the scope and lower down, you don't see the tip. So you have to rotate at least 90 degrees to the head of the patient and lower down the scope to zoom. After you drill enough, you start the cutting of the ligament from medial lateral fashion and use the cannula to stretch the ligament. And when you cut laterally, you have to cut laterally above the tip of the ascending facet, and you have to rotate the scope a lot to see. Here now we start the ligament cutting, and you press the cannula down to stretch the ligament. When you cut, you have to rotate the scope to see the tip of the instrument all the time. Cut medial and then cut lateral alternatively. You see, if it becomes deeper, you rotate the cannula to find the way to stretch the ligament here, and then you can cut until you enter into the spinal canal. Here become thin, the color change. The last bite is very important. You have to keep pressing the scissors, but not too much. Here we enter the spinal canal. So I change from the punch to the ankle punch. So the cutting edge is to the ligament and away from the thecal sac. And I have to rotate the scope even more than 90 degrees. It's almost 150 degrees to see underneath the ligamentum flavum. I demonstrate now. If I cut without rotate the scope, I can cut but I don't see what's happening underneath the ligamentum flavum. So better rotate the scope. Now we see the inner surface of the ligamentum flavum. And you cut laterally, you have to rotate the tip of the cannula away from the facet joint. Otherwise, you will stuck the system with the facet joint, and cut above the tip of the ascending facet. So it's a foraminal zone of the exiting nerve. You see the facet joint, ascending facet, descending facet, and you see the ligamentum flavum. You see the tip of the cannula. It's normally I place it on the lower lamina level. So you start to approach to the lateral recess, and you want to expose the lateral recess from the shoulder down to the lower lamina. You see the tip of the cannula is against the facet. You don't have a lot of motion, so I rotate it down to sit on top of the lower lamina. And I can use the correction to cut the ligament more downward. I'm looking upward now, so when I cut downward, I rotate the scope other way around, 90 degrees to the leg of the patient, and now on the left side is a facet joint, right side is the traversing nerve already. So you have to see the tip of the instrument all the time. That's the key. Okay, so now 12 o'clock is the lower lamina. So you don't have to do this, but if you have the high-grade migration down, you want to see more on the lateral recess, you can remove the ligament even down to the lower lamina, as I'm showing. You start to see the epidural fat, see some bleeding. Okay, so you have to see, lower the scope to see what's happening at the tip of the instrument all the time. And if you face with the bleeding, you use the coagulator, the coag mode, to coagulate. And this is the lateral recess. We can press down and then coagulate. So now we see the traversing nerve. I rotate the scope back, and again rotate the scope to the head to the head of the patient, and I coagulate the epidural vein on the lateral recess. The next step is very important to identify clearly the nerve root and the PLL. You have to remove the epidural tissue. So use the rongeur to remove clearly the epidural tissue fat, but remember to lower down the scope and rotate the scope as necessary to identify what you are grabbing. You don't want to grab the dura. So before you pull it out, you have to lower the scope and look around. So in this, I illustrate how to remove the epidural tissue above the nerve root and the thecal sac and in the lateral recess. And then when you see clearly, you can coagulate the epidural tissue. You can feel the ground, which is the PLL, and underneath it can lie down the herniation tissue. And there are two ways of retracting the nerve root. When the compression is very severe, the space of the recess is very tight, you don't want to put the whole system down and start retracting, that which can create the complication at the beginning. You can use the probe. As I show now, you can use the probe to enter to the recess, and then you rotate this. Here now, we rotate the scope in order to place the probe down, and then rotate it back, and then you can retract the nerve root, and you can find the bulging part. And most of the time the disc is beneath the PLL, so sometimes the PLL is very thin here, and you can have the herniation part coming out through the PLL, and I can retract a little bit and open the PLL with the probe. And then by doing this, you can have the free fragment coming out without retracting the nerve root with the whole system at the beginning here. And then we can grab this free fragment out before we put the whole system down. And another way is to retract the nerve root with the cannula, and you will make sure that you have the firm contact between the cannula and PLL before you start retracting, and then be sure that you retract the nerve root, not the PLL and the free fragment with the nerve root. Here, after remove some free fragment, I place the cannula with the tip down on the lateral and rotate 180 degrees, and you have to keep pressing to keep the contact between the tip of the cannula and the PLL, and coagulate the vein. And you can close the cannula completely and keep pressing on the cannula and remove the free fragment as you see, and you see the tip of the instrument all the time is the key. Right now, I grab the free fragment that protrude through the PLL, and then next step, we can enlarge the PLL by cutting it, but be careful not to cut the annulus because we want to spare the annulus. You know, the bigger the annular tear, the higher the chance of the recurrence. Okay, so we can open and see the nerve, and then you can use the tip of the cannula to squeeze on the PLL, and then you can squeeze the free fragment out. And I cut to open the PLL. This is the lower end plate of the L5. And then you can use the coagulator to shrink down all the tissue, the PLL, the end plate is on the left, and this is the annular tear. Okay, just coagulation around as a PLL. You can still see the PLL. Many times that we have to cut to open the PLL in order to see the annular defect completely and remove the free fragment, which I will show you later. So the next step is to remove the intradiscal free fragment. So after you remove the free fragment that compress the nerve, so the nerve will become loose and you have more time to go through the annular defect and remove the free fragment in the disc. Now the nerve become free, and then I rotate. I try to identify all the annular defect before I grab the interdiscal free fragment. It's a bleeding. When there is a bleeding, you want to lower the scope closer to the bleeding to see more clearly and use the RF. Once you press and the bleeding become less, you can coagulate shortly, not too long. And this is the bleeding from the epidural vein. I'm looking down. This is near the lower lamina. And then when you do the retraction, this epidural vein can create the bleeding. So better use the sharp cut to cut the epidural vein to disconnect, and before you start to retract more to the medial. Okay. Here we cut the epidural vein, and then you can rotate the cannula completely to retract the nerve. Here, sometimes you can do the partial, not to see the nerve all the time. If you want, this is the annular tear, and there's some part. This is the lower end plate. This is the L5 end plate. Okay, so now almost always there's a free fragment at the annular tear and interdiscal. So I grab more. This is the annular tear. We don't see the annular tear clearly yet because the PLL is on the way. So after I remove some part between the PLL and the annulus like this, always a free fragment at the annular tear. If you don't remove it, the nerve is clear, but you can face with the recurrence. And then I would cut the PLL to expose more the medial part of the annular tear. Here again, you see the shiny ligament. That's a PLL that cover the medial part of the annular tear, and almost always the free fragment is underneath. Okay, so I cut more the PLL here, and be sure that you see the tip of the instrument all the time. Okay, cutting the PLL here. Now we start to see more the middle part of the annular tear, and you can use the angle wronger to grab the free fragment underneath the middle part of the annular tear. Remember from the MRI, the free fragment extend almost to the midline of the spinal canal, so we don't want to miss that piece. And again, when you go into the intradiscal, you want to look for more free fragment or some abnormal vessels, inflammation, that you can use the RF to coagulate, so-called the annuloplasty. So you can rotate the scope 180 degrees to inspect around intradiscally to see if there is any more free fragment, and you use coagulator as the finger to do the soft curette and coagulate, and then you see the nerve root. Here again, after you have the free decompression and you look around up and down, you can make x-ray to see how much you decompress up and down. And you see the pulsation and take pictures for the patient, and you see the annular tear. You want to see the cavity right beneath the annular tear. If you don't see this cavity, that means there's still the free fragment plugged at the annular tear. So you want to remove more in that situation. So this is the advantage of the INTERLAMINAR. The real advantage is to remove clearly the intradiscal part and be able to explore the intradiscal. So my take-home message is the INTERLAMINAR approach widens the indication for the endoscopic spine surgery, and the proper handling of the system is very important in order to maximize the benefit of the endoscopic view. Thank you very much.
Thank you very much, Dr. Varipan, for this great presentation. In the meantime, we received some questions from participants today, and we will start with one question from our own faculty. I guess Dr. Varipan wants to ask the question for Dr. Arun Bhanot. Dr. Varipan, your question? Can you hear us?
Yes.
Yeah.
My question is, how do you select which patient you will do the foraminoplasty and which patient you think you need to do the interbody fusion like T-lift?
Can you unmute Dr. Arun?
Yeah. Am I audible now?
Yeah. We hear you.
So the foraminoplasty procedure for foraminal decompression is indicated for patients who have dominant symptom, disabling symptom of leg pain, radicular pain, or claudication arising out of only foraminal stenosis. If the patient has instability, there is a combination of central and foraminal stenosis, and there is an equal or more dominant back pain along with radicular pain, then these patients may not be a good candidate for pure foraminal decompression, and it is better to consider a T-lift or a fusion procedure in those patients.
So the height of the disc space is that the factor that you consider, like in my practice, if I see a very collapsed disc, that means the spondylosis is quite advanced. It will not collapse down anymore. I do the foraminoplasty, but if you still have a certain disc height, it may progress. Maybe you will shift to do the fusion instead. Is that a consideration?
Usually, even if the disc height is there and the foraminal stenosis is because of the telescoping of the facet joint, there is always some kind of disc height loss. But if the patient does not have significant mechanical back pain, we discussed this, that we can treat you with the minimally invasive decompression to relieve the symptom now. And if you develop some back pain in future, we can consider a fusion. But if the patient says that, no, I want a one-time solution, then it is better to switch over to the fusion procedure in those patients, that particular subgroup of patients.
Okay, thank you very much. Probably another question from one participant from Nigeria regarding this foraminal resection, bone resection. Is there a fusion sometimes required if you resect too much bone, or are there limitations for doing that, or where's the limit, how much bone you can resect?
So foraminoplasty and foraminal decompression is a very targeted surgery. So we dock the cannula on the anterolateral surface of the facet, and whatever the facet drilling is done is of the non-articulating part of the facet. And the amount of facet drilled to remove the compression is very minimal. I showed in the post-operative CT scan comparative decompression. So you could see that most of the CT scans will show only 15 to 20% of the non-articulating part of the ascending facet is drilled. So that does not usually cause any instability that would warrant a fusion in such cases.
Okay, thank you very much. We have another question to Dr. Siepe. For the interlaminar approach, which anesthesia do you prefer? Is there a possibility for doing that in local anesthesia?
I think that in some cases you can actually do it under local anesthesia, but it's just my own personal preference to do it under general anesthesia, simply because I think that it's more comfortable for the patient. And you may always remember there may be situations during the surgery that are unexpected to the surgeon, where you encounter difficult situations. And then I think also it's also uncomfortable for the surgeon, puts you under unnecessary stress. And I think it's better if the patient sleeps for 30 or 60 minutes, and then you can do your surgery. And I think it's just not much more comfortable for the patient and for the surgeon. So that's our preference. However, we do not give any muscle relaxation, but we do all the procedures under general anesthesia.
Thank you. How about you, Dr. Varipan? Dr. Varipan? Dr. Varipan? He cannot hear us now.
He's muted himself.
And Dr. Arun?
Most of my interlaminar procedures I do under general anesthesia.
Yeah.
And local anesthesia in the early part of my endoscopic journey for transforaminal as well as interlaminar, I used to do under local anesthesia. But as after gaining a lot of experience, able to recognize the neural structure, I feel it is better whenever there is a possibility of general anesthesia, because the patient lies comfortable. There's no need to keep asking the patient to relax. So that gives a lot of comfort to the surgical team to do your procedure quickly rather than do it under focus. But there are some patients, elderly patients, who may not be suitable for general anesthesia. Then they can be treated under local.
Okay, thank you very much. Dr. Varipan, now we can hear you back. Just one question regarding your practice. If you, in your daily practice, what is the range of interlaminar approaches compared to transforaminal approaches in your daily practice?
If you ask me, we have been doing more than 1,200 cases. I would say I do 90% interlaminar. The reason is for the disc herniation, I have more confidence to do intradiscal removal from interlaminar compared to the transforaminal. And I do transforaminal for the large central herniation that I don't want to retract at the beginning. And I always combine with the interlaminar to remove intradiscal free fragment. And another indication for me is foraminal stenosis, foraminal disc herniation, or extraforaminal herniation that I do lateral, also called extraforaminal approach. So, and we do every case under general anesthesia. I agree with the Professor Christoph that it's more comfortable for the patient and for the doctor as well.
Yeah, okay. Thank you very much.
So, Dr. Vilpan, Dirk, can I ask something?
Yes, sure, please.
So, Dr. Veerappan, when you're doing the interlaminar approach, and sometimes there's a large herniation in the axilla of the nerve. So, would you decompress it from the axilla in the beginning, or you will always go to the shoulder, try to retract the nerve and see the lateral surface of the nerve and then try to retrieve the fragment from there? Sometimes it is very difficult to stabilize the nerve in the presence of a large fragment in the axilla.
When I have large fragment, the first thing I do is I open more the ligamentum flavum to medial, more to caudal and cranial, and I want to see the normal dura, normal nerve, and then I see that remove the epidural tissue until I see the disc fragment, and if it's easier to remove through the axilla, I remove through the axilla first, okay? But when I grab, I make sure that I use the rongeur to grab parallel to the nerve, not across the nerve. And then I have to rotate the scope, both sides, to see what I'm grabbing, because you can grab either the dura or the medial side of the nerve root easily. And then after that piece is removed, so I retract to do intradiscal later. I don't retract at the shoulder all the time.
Thank you.
Welcome.
Thank you very much. One question to Dr. Siepe, probably, from China. We got a question regarding cutting the PLL. When you cut the PLL, or how often you cut the PLL in cases of disc herniations, probably, is there a risk for increasing the recurrence cases?
Yes, there is a risk of a higher recurrence rate. So whenever possible, I try only to do a sequestrectomy and leave the disc intact. And I see from a lot of visiting doctors, when they see cases where there is a little bit of bulging, that they would tend to go there and open up the disc. And I always discuss these cases, because I think as long as you can leave the disc untouched and you can see that the nerve is decompressed, then rather leave the disc untouched. So we try to only do a sequestrectomy if you have to open the PLL, because there is a really still large disc herniation or bulge extruding from the actual disc. Well, then there is no other option. Then you have to open the PLL. But I try to avoid it.
Okay, thank you very much. Another question to Dr. Arun Bhanot regarding the foraminal and extraforaminal stenosis at level L5S1 with high iliac crest. How do you treat that?
So we have to understand that when we are talking of foraminal and extraforaminal stenosis, the iliac crest usually is not a problem, because your target is outside the canal. So you can just dock it vertically, just about 5 to 7 centimeters away from midline, and that will give you access. The case I showed you was at L5S1, and the cannula was more like vertical. If you look at it, the cannula will look as if you are doing an interlaminar kind of an approach rather than a very flat horizontal foraminal.
It's more an interlaminar direction of the approach for L5S1 in the most cases. Yeah. Thank you very much. So now we continue with the lecture of Dr. Siepe from Munich. He will talk about central spinal canal stenosis and bilateral over-the-top decompression. And we will start the presentation. We cannot hear you. Hello?
Can you hear me now?
Yeah, we can hear. Yeah, now we can hear you. Yeah.
And can you also see the presentation?
Now not. Now not. Now we see you.
Okay. Then let me try again. Let me see again. Okay, but now you should be able to see the presentation.
Now we see the presentation and we hear you. Yeah.
Fine. Okay, so this is all live, you can see.
Yeah.
Okay, so I will be talking about the over-the-top decompression for spinal stenosis. We know that spinal stenosis is a very, very common problem, especially in the aging patient population that we encounter in here. So this is why we always want to reduce the invasiveness of our procedures. And over the last decades, we have gone from open decompression, and we made a huge step, and we made huge progress with going microsurgically. And now, from my point of view, the logical next step is to do these kind of procedures in a full endoscopic fashion. So this is a view into our operating room. You can see here, this is how we work. This is we get everything onto large 4K screens. We basically do all kinds of procedures for the full decompression through an interlaminar approach. Everything is projected onto large HD screens or 4K screens. And then you can do these kind of surgeries with just a stitch suture. So it's really, really minimally invasive, as you can see here. So this is what I will be talking about. Please don't hesitate to write down all the questions that you have, and we'll go through them later on. So as you know, there are different approach techniques how to do a full endoscopic surgery. And you can do it either with a transforaminal approach, a posterolateral approach, or an interlaminar approach. But these are the structures that we want to decompress in order that we want to remove in order to get a full decompression of the central spinal canal. So this is the hypertrophied facet joint and the hypertrophied ligament. So this is what we want to decompress and what we want to remove. So as you can see here from this picture, if you choose a transforaminal approach, you will not be able to reach the central structures or the contralateral structures unless you remove the entire facet joint, which is not what we want. And same thing applies to the posterolateral approach. So when we talk about an over-the-top decompression for the treatment of central spinal stenosis, we really have to go and choose the interlaminar approach. I'm saying this because even within the endoscopic scene, there is often some kind of a, let's say, a debate. What is the best technique? Is the best technique the interlaminar approach or the transforaminal approach? I think this is not correct. So some cases you have to treat via a transforaminal approach. In some cases you have to treat via an interlaminar approach. This really depends on your pathology. But central spinal stenosis, if you want to treat that in an over-the-top decompression technique, then you have to go via an interlaminar approach. So we kind of have a different concept here. We have a number of really nice video clips that I will show to you now, which a professional film team from Revo Spine did with us in Munich. And let me show this first case to you, this first video, which presents the case that I will be demonstrating to you just now.
This is a case of a 70-year-old male patient. Clinically, the patient has got symptoms of spinal claudication, bilateral leg pain, reduced walking distance, gait disturbances. What we can see here in these images is that at the level L4-5, there is a significant compression of the neural structures. So we can see this here in the sagittal view. I think first of all, to show you the tips and tricks, what do I look at when I analyze these pictures? So first of all, I look at the x-rays. There is the segmental collapse at L5S1, but back pain is not the problem. And then I'm looking if there are any instabilities. There are no instabilities here. There is no rotation. There is no scoliotic deformity. So that's what I would analyze. We can see here that there's no major rotation. Same in the axial views. So really, if you access this from the left side or from the right side, is for one surgeon's preference. But in this case, I decided to go from the right side because the patient simply has slightly more complaints on the right side in comparison to the left side. So he said it's somewhat 60-40 predominant on the right side. What else do I look at? I look at the axial views, and we can see here that a lot of this spinal stenosis that you can see here is attributed to a hypertrophy of the yellow ligament. So that's what we analyze. I look at the plane and the orientation of the facet joints. So they are around about 45 degrees oriented, which is also nice because we can preserve a lot of the facet joint. We don't have to remove much of this. And yeah, so that's what we'll do. We'll make our incision here at the level L4-5 over the interlaminar window. This is a case.
Okay, so we have seen the case presentation. And now the next step is we will go to the operating table. And the first step is that we will mark our skin incision over the interlaminar window. This is what I will be doing now. You can see we take away the plastic foil.
Okay.
And then you mark it on the skin incision. Right paramedian.
You make a small skin incision, let's say around about 8 millimeters, and you just go down and incise the fascia paramedian right next to the spinous process. Then you go down.
Okay, so once we have done that, we've made our skin incision. The next step is that you need to put in the tube and the sleeve. And this is actually a really nice part of the surgery. I'm really enjoying this because you're doing your entire access within 20 to 30 seconds, independent whether the patient is 60 kilos or 160 kilos. So I will be demonstrating this in this video here.
Onto the interlaminar window, and now I can already feel the ridge from the facet joint to the interlaminar window. I can feel this here. One bit. No? And this is basically your entire access preparation already, which you can do in 20 to 30 seconds, which is really nice. And this is independent of the patient's weight. Whether the patient is 50 kilos or 150 kilos doesn't make any difference. So then we insert this instrument, the tube, and you can see here that this is facing into this direction, so I always know where the opening of this tube is. We go down here. Okay, du kannst einmal ein Bild machen.
Okay, so you can see our tube is already inserted. Next is we insert our endoscope, and from then on, everything is done under full endoscopic visualization. And first of all, obviously, we need to get our orientation. We need to expose the bony structures. We need to see the interlaminar window. So this is what I will be doing now.
So now, schwung ein bisschen mehr lang. So now we are creating our access to the spinal canal. We have to remove this soft tissue, which is in front of the interlaminar window. And just for your anatomic orientation, the image for you is exactly the same way that the patient is lying on the operating table. So this is lateral, this is the facet joint and the facet joint capsule. This is cranial, this is where later on we will see the lamina. This is then where our interlaminar window will be coming. This is medial, and this is caudal.
All right. So then, next video, we need to open our interlaminar window because obviously the interlaminar window, this is like kind of the access in order to get to the spinal canal. So we need to open up the interlaminar window. We need to expose the yellow ligament. And this is what I will be doing here in the next video.
So the next step is we need to open up our interlaminar window with the burr. In order to be able to do so, we will have to remove some of the soft tissue from the facet joint capsule. And this is what I'm doing now. These are the sharp scissors. You can remove some of this facet joint capsule material here. Simply that for the burr later on, it'll have a better grip on the bone, to open up, and it'll be easier to remove it with the burr. Dann mal ein Bild. Alle beschützt? Ja. Das ist gut. So, we have confirmed that we've got the right level. What is important for you is that when you use the burr, it takes a little bit of practice in the beginning to get used to it. You can see that this sleeve here is resting on top of the bone, and we can nicely move cranially, caudally, left and right. The burr will be a little bit deeper, going into the direction of the interlaminar window. Okay, and that way then you can nicely move around the burr. If you go too deep with your sleeve, like I'm doing now, then you will not be able to move around. You will be stuck. It's always important that you confirm that your sleeve is on top of the bony structures. And then, like you can see now, we can nicely use the burr. I will have to extend my interlaminar window cranially and also laterally. Lateral will be part of our recess decompression. You can see that now very controlled. We'll open up the interlaminar window.
I think this was a nice video for demonstration purposes. It looks pretty easy when you see how to work with a burr, but I can tell you when you start learning this technique, it's a little bit challenging, and that's why I wanted to point this out here in this video clip. It's really important that the sleeve stays outside and the burr is a little bit deeper, and then everything is nice and sliding and easy movement. And otherwise, when you think that you have to use force, then probably you are doing something wrong. So this is why I would like to point this out one more time. So now we open up our interlaminar window. We have exposed the cranial lamina, the facet joint, and this takes us then to the next step, which is the yellow ligament resection.
I usually start here towards the lamina, going cranially, and then I start to go lateral here in the part of the recess in the craniocaudal direction. I think what's important to note, this step of the surgery, I'm doing the majority of this bony work whilst the yellow ligament is still intact. Once I've done this, then I will remove the yellow ligament and then I will do the rest of the bony work here in the recess. Okay, so we will now start to detach the yellow ligament from up here. Kannst du mir mal einen Dissektor geben? You can either put it down, you can already start cutting with the small Kerinson. I would start with the small Kerinson punch here. In this case, I decided just to put it down. You can see epidural fat tissue coming here. Ipulama. Stand's klar? Ja, wunderbar. Stanze groß. So now this is the next step of the surgery. We've got a nice layer here. There are no adhesions, pupilla.
So this is a very essential step during any part of the surgery, whether you're doing simply a discectomy or whether you're doing an over-the-top decompression. You need to remove the yellow ligament and spinal canal stenosis. If you only want to do a discectomy, then it's actually enough to just create a tiny 2 to 3 millimeter little opening, a little gap in the yellow ligament, and then you can basically sneak in with your scope into the spinal canal and remove the disc herniation. In this case here that I'm showing to you now, the yellow ligament hypertrophy is really part of the underlying pathology. And that's why we want to remove the yellow ligament completely. You saw one option here that you go to the cranial lamina and you detach the yellow ligament from the cranial insertion underneath the lamina, pull it down and start resecting it. That's one option. The other option is you could also go straight through the yellow ligament basically and start it more from the middle and then go cranially or caudally. So both options are really available.
I usually start here
So then, this takes us, we have decompressed the central spinal canal now, and now we want to do the ipsilateral recess decompression. This is what you will be able to see in this video clip here.
Obviously, we want to preserve facet joints, so you don't remove too much material, only so much that you can clearly identify the lateral border of the dura and of the nerve root, so that you can confirm that there is no more compression. And this is what we have done right now. I think we have now reached the lateral border of the dura. We want to make sure that this is fully decompressed. And here we go. It's the lateral border of the dura. You see the disc here. Yeah, so like I said, every single step is very controlled. And now we're going along this line. This still needs to be removed until we can see the exiting nerve root. Hier noch einmal die Fräse. Haben wir jetzt die Diamantfräse? We don't really need it here, but this is maybe for demonstration purposes.
So this is very important. What you want to see is, you want to see this is the lateral border of the neurostructures here, and you want to see that there is no more compression here. So all of this material that is still here in the coated part, this still needs to be removed. This is a very, very essential part down here, because this is where the nerve root will start to move out of the spinal canal and take a more lateral orientation. So this really needs to be removed. This is what we will do later before we start our over-the-top decompression. So we have now decompressed the central spinal canal. You can see that here in the ipsilateral recess, I will show you later again, we've done a full ipsilateral recess decompression. We know that the exiting nerve root here has been fully decompressed. And now what we want to do is later on we want to do the over-the-top decompression. So this is what we will do here. So let's check the central spinal canal.
The ligament from up here, from the cranial insertion. The central spinal canal in this area is decompressed. We will still have to go over the top, down here. And now we check the lateral border of the dura. You can see it's all decompressed. There is a disc here. There is a bulge of the disc, but I'm not going there because we don't want to weaken the disc. Then here is the exiting nerve root. You can see this here, there's a shoulder of the nerve root, there's a pedicle here. This is countable of the disc base already. Now we know that on this side, everything is fully decompressed.
So what I really like about this video and what you can see here is that you have a really perfect visualization of the neurostructures. You can see everything the way that you are used to seeing when you do these surgeries microscopically, but from my point of view, the visualization is even better. So that's what I really like about the surgery. So let's go over the top now in this coming video clip.
So the next step is going over the top. We will have to remove these parts. Stanze, Jumbo geradeaus. Yeah. You simply tilt the scope now to the other side. Same thing, I'm checking if there are any adhesions here. So you can go in with a bipolar. You can see that there is a lot of compression coming from the yellow ligament.
just here, you can rotate the camera, and then you can actually really see what you are doing with the instruments, how you're taking your bites. This is very important so that you don't cause any problems, such as dural lacerations. So you can really make it a very, very good tool working for you, this 25-degree optics of the scopes.
So the next step is going over.
So then once we have done that, last but not least, we have decompressed. It's basically the same what you would do microsurgically. You see the neural structures, you see what needs to be removed. You might have to remove the contralateral bone. You will have to go all the way into the contralateral recess, and then you need to remove anything that you think needs to be done so that you get a full-on decompression. And then at the end of the surgery, you check everything one last time. And this is what we're doing here now. We're doing the final inspection.
We're getting towards the pedicle down here. Again, quite far enough caudally. Exiting nerve root is exiting freely here. I'm trying to, I will just show you a little bit. Yeah. There is a pedicle right here. There's no more compression here. So you can see, this is our final inspection now. Contralateral recess is fully decompressed. You can see the exiting nerve root down here. There's the pedicle down here at about 8 o'clock. So we rotate the scope so that we can nicely see everything. Everything is here decompressed. Okay. Now we go to the ipsilateral side. That's the lateral border of the dura. Central part of the spinal canal is fully decompressed.
All right, so you can see the neural structures have been fully decompressed.
Towards the pedicle down here.
And yeah, then you finish the surgery and you know that you've done the job and that there is no more compression. Just some tips and tricks. We have various scopes. The smallest one, which we use for the posterior cervical procedures. The middle one that you can see here with a 4 millimeter working channel, this is what we use for soft disc pathologies and the lumbar spine. But for over-the-top decompression of spinal stenosis, I would really recommend that you use the larger scope with a 5.5 millimeter working channel, simply because it's a little bit bigger, you have bigger instruments, and it will make the surgery a lot faster and a lot more comfortable for the surgeon. I also recommend, as with all types of surgery, start with easy cases. The easy cases are usually the ones where you don't have any instabilities, where you don't have any deformities, and which are predominantly based upon a hypertrophy of the yellow ligament. So when there is a lot of stenosis from the bony structures, that's a little bit more challenging maybe. So maybe start with cases such as the one that you can see here. In a number of cases, especially when we started this technique, we did pre- and post-operative MRIs just to see, have we done a sound decompression. It doesn't really make sense only to make a small skin incision, but then the actual technique is not so good. So we wanted to check ourselves, have we done a good job? And you can see here some pre-operative MRI images, and then post-operative MRI, which we did only 48 hours later. You can see here, there's a full and sufficient and sound decompression of the neural structures. The post-operative regime, patients are mobilized as soon as the anesthesia wears off. So I would say about 3 to 4 hours after the surgery, the patients are fully mobilized. There is no need for a brace. And in Germany, the patients have to stay for 48 hours after the procedure, which is only DRG related. So there will be a substantial deduction of the amount that we are being reimbursed from the insurances if the patients go earlier than that. So that's why they have to stay for 2 days. I hope that this will change over time, because actually I think that in a number of cases you could actually do some of these procedures on an outpatient basis. Huge advantages from my point of view, especially in very strong or very obese patients. You do the same kind of surgery, very small skin incision, 7 to 8 millimeters. You can do single level or double-level decompressions, as you can see here. This was a case, 140 kilogram patient, or even 3-level decompressions if you feel comfortable. We know from microsurgery, when you're trying to make the skin incisions very small, sometimes we tend to put too much pressure on the retractor system, and this is what we end up with, maybe infection or wound healing problems. This is what I would say we can almost eliminate the risk of infection or wound healing problems with the endoscopic technique. For a number of reasons, because the incision is very small, because there is no retractor system, there's never any pressure on the wound, because we have a lot of irrigation from saline solution during the entire surgery, and so on. So with respect to infection or wound healing problems, you get as close to 0% as you can possibly get. I would say you can almost even almost eliminate this risk of this type of complication. From my point of view, when you're starting to learn to work with an endoscope, I would recommend take your time. The goal is not to do all kinds of surgeries now within 50 or 20 minutes. It will not work. You might face complications if you're trying to do that. So really give yourself some time, start with easy cases. So maybe start learning this interlaminar technique, easy discectomies, L4-5, only later go with L5 is 1, only later go to the level L4-5. This is where you can start to use the burr, then you can do your first recess decompressions, then you can do over-the-top decompressions, and then last but not least, you can do cervical spine procedures. So this is how I would recommend take it step by step. Otherwise, lots of teaching materials out. Our webinar online conference today is one of them. We have a lot of stuff out there on YouTube. We published in all kinds of journals. We're doing our courses. So really look at it, and before you're doing your first cases, maybe go and visit one of the more experienced surgeons and look at how they do these procedures hands-on when you go there and you watch it, and then you go home and you do your first cases. So thank you very much for joining this webinar, and I'm looking forward to answering all kinds of questions that may have come up for the last 20 minutes.
Thank you very much, Professor Siepe, for this great lecture and the video demonstration about the technique. I mean, it helps a lot if you want to start the techniques, to do it step by step and to have some examples for doing that. We have received 2 questions in the meantime. One question is about nerve root damages and dura damages. Is there a possibility for suturing, or how to deal with that, or covering that? And the second question is about the epidural or the steroids. Do you use some, or do you put some steroids inside this approach when you close the approach, the skin incision?
So first of all, the first question was with respect to nerve root damages or dura damages.
Yeah.
So first of all, there should never be any nerve root damages. So that's the one thing. You always see the neurostructures. There's absolutely no reason why you should damage the neurostructures. It's a different story when we talk about a dura lesion. These things can happen when you have adhesions, when you're trying to do remove synovial cysts. They can sometimes be very adherent, or especially when you're doing revision cases, then you can have a lot of adhesions, and then you can actually have dural tears. So the strategy kind of depends on how severe this dural tear is. If it's an extremely small, let's say just a tiny puncture, then you can actually leave it, and because there's not a lot of dead space volume, so there is still a lot of compression. You don't have a big cavity. I would still prefer to put on a sealant, just as a Tahosil, for example. If you have larger tears, then you can also treat it endoscopically, and you need to suture it. There is also a possibility to do that. If you feel uncomfortable, well, then I would recommend don't hesitate. It comes first, and then you need to make the incision a little bit wider, and convert to microscopically, for example, and then really suture everything so that you know that everything has been closed. The second question, Mr. Goethe, was which?
About steroids. Do you put some insight when you close your approach?
For decompression of spinal stenosis, I don't do this anymore. There was a large study from China many years ago, and the study published that radiculopathy will resolve a little bit faster in patients where you do apply steroids. And I think this is where this question comes from. So in some cases of disc herniation, I apply a little bit of cortisone, but to be perfectly honest, I've become very cautious to apply it into the spinal canal. You know, cortisone weakens all kinds of structures, whether that is the biceps tendon when you do it in the shoulder, or whether it's the Achilles tendon when you do it applied there, or it can also weaken the actual dura. So I've become very cautious doing that, making it in some soft disc herniations, but otherwise less and less.
Okay, how about you, Dr. Varipan? Dr. Varipan? Are you using steroids for that? And any experience with dural injuries and how to deal with that?
The first question, the dura injury, if you think you have to repair it, either if you have enough instrument to repair endoscopically, or if not, you have to convert to micro and repair it, and then you continue the surgery. Because if it's big enough and you don't repair it and you keep on surgery, number one is you push water into the subdural space, or if you have the tear arachnoid as well, it's going to the subarachnoid space. Number one, I lower the pressure, and then I see if I have to repair it. Okay, so if it's not big enough, you continue the surgery. For the decompression, you don't have to retract the thecal sac. It's quite okay. But with the disc herniation, if you have to retract the thecal sac and the nerve to get the disc, you can see the root coming out the defect. If the defect, even the defect is not that big, but if the arachnoid is already tear as well, okay? So tear dura, but spare arachnoid is better than tear dura and tear arachnoid. The nerve root come out easily if you have to retract, so you have to repair it first. And the second question is the steroid. As a normal practice, if we don't have contraindication, we put the steroid at the end of the surgery. But frankly speaking, we don't think it's a must, because we have a lot of water inside, and they wash out 90% of the steroid that we put already, but it's become routine that we put, but I think it's not necessary.
Okay, thank you. Any comment from you, Dr. Bannot?
So the dural tears, as already mentioned by Dr. Sikpen Verapan, most of my experiences with revision surgery of the interlaminar when I encounter a dural tear. So if the tear is small, I can use a Sacco seal just to at the end. And once I had to convert because the tear was compact, so there's no need to hesitate to convert. And I use steroids in disc herniations at the end of the procedure, and usually not in stenosis.
Okay. Thank you. Dr. Varapan, you have some comments? We cannot hear you.
I agree. I think the dura tear with the ipsilateral, it's rare. Okay, it become more common with the central stenosis. Number one is like Professor Sieber, is the adhesion in the very stenos. And number two, which is more common, is the flow of the water and make the posterior part of the dura like a cleft. And when you use the big correction to cut ligamentum across to the opposite side, and if you don't see it exactly, you can cut the dura fold together with the ligamentum flavum. at the posterior part of the dura. That's the most common place of central stenosis.
Okay, thank you very much. There's another question. I see. There's about methylene blue for using methylene blue for indications. We did not see that with the interlaminar approach. Are you using sometimes methylene blue for transforaminal surgery, Dr. Banot, probably?
In the early part of my career, I did use the methylene blue, but because of the problem of availability, I stopped using it. It would help me to differentiate structures early on, but after gaining experience nowadays, I'm not using methylene blue for the last several years.
Yeah. Okay. Thank you very much. And we got another question from Dr. Wheel. In revision cases, any tips? Same side or opposite? That means the principal question is for revision cases, would you do it interlaminar and in the most cases, of course, the first surgery was done in interlaminar or microscopic case, and if you do a revision case, would you do it transforaminal or would you do it interlaminar for the revision case? And this is the first question, and probably the second question. Are you sometimes using the ipsilateral approach to approach the contralateral side, even for cases for disc herniations? Are you doing that, or have you done this so far? Dr. Siepe, probably?
I sometimes have difficulties trying to answer these types of questions because, you know, the patient pathology is often so specific and trying to answer this is so broad. So I don't think that I will be able to give the right answer to this question. I mean, if you do a discectomy through an interlaminar approach and you have a current disc herniation on that side, then you might have to go back, just like you would do with a microscope. It doesn't essentially change anything. I mean, I had a case yesterday where I had to do a revision. Surgery was done 6 years ago, 6 years ago in 2014, and now 6 years later he had another recurrent disc herniation at that level on that side, and I will have to go back through the same approach. My tip here is always stay close to the bony structures. If you've done a previous endoscopic discectomy and you have only removed very, very little of the yellow ligament, then in many cases you still find a lot of native yellow ligament, which you can go through then later. So this is then try and insert the spinal canal through a healthy, untouched approach, and then go to the old scar tissue. That's what you can do. If you don't have that option, then I would really recommend go down on the facet joint and then stay very, very close to the bone and go all the way down to the disc space, but stay close to the bone. Don't try to work in the area of the scar tissue, because then that's when you get when you have a higher risk of having dural tears.
Mm-hmm. Thank you, Dr. Banot. Probably your opinion about that, about revision cases done in the previous case microscopically with the interlaminar posterior approach. Are you using the transforaminal approach for that as well? Because this is not touched so far. We cannot hear you. Can you unmute, please? Yeah.
My decision is guided by what is the general principle of endoscopy. If the pathology needs to be assessed, which is the best approach to drill that pathology. If you feel it is the foraminal approach which will address the pathology better, we will use that approach. If it is the interlaminar approach, we will use that approach. It does not matter, and especially if we have already done an endoscopy in the past, that is very easy to do a revision. But even with the previously open or microscopic approaches, you can follow the principles of your microsurgery, that you first reach the lateral edge of the facet or a bony landmark, and from there on you can dissect and reach the pathology.
Thank you very much. And we have a last questions probably for today to Dr. Varapan. Do you have to worry about meningitis or subarachnoid hemorrhage after dura tears? Do you have an experience with that? Have you seen one?
I have the dura tear that I have to repair. I remember during the first 100 cases, I have 2 cases, and during the first 50 cases of the central stenosis, I have 1 case. We don't have that problem, but meningitis. You mean headache?
Yeah.
Meningitis up there. I don't have that, but some patients we observe that they have more back pain than normal post-operative patient. And I would like to address a little bit about the previous questions. Normally I do interlaminar, so if I have to do the recurrent disc herniation, that I have to do the anterior decompression, discectomy. I always drill to find the virgin plane, even post-micro or post-endo, because you can find the virgin plane underneath the facet, and then I slowly resect backward to the traversing nerve and remove the herniation, which is normally underneath or the adhesion. This is what, the answer. Another question is, if you do contralateral approach to do decompression, it's possible with the posterior decompression, okay? Because some surgeons, they say, if you cut from the same side, you cut more facet. But if you cut from the contralateral side, you do the undercut of the facet. Maybe it's more to preserve the facet joint. Feel free to do that, but don't do the anterior decompression. That means discectomy, so-called, from the contralateral side, because the degree of the thecal sac retraction is too much, and you can create the post-equina syndrome. So this is the only option when I have to switch side to do the anterior decompression to the opposite side, if I think I need to do it. But posterior decompression, you can do over the top easily.
Thank you very much. Thank you very much. So no questions is open left now. I want to say thank you very much to our international faculty, to Professor Siepe, to Dr. Varapan, to Dr. Bhanot. It was really nice, and it was our pleasure to join this session with you, and that you could join all your experiences and excellent presentations and videos with our international faculty. Thank you very much for taking your time.
Advertisement for our
Sure.
workshop in January next year, which date is the 29th and 30th of January. So we're gonna do the webcast. The first day will be I think the Friday will be the lecture from Professor Rutten and from my team, and then I will perform live surgery to cases transforaminal and interlaminar. January, I think Dirk will inform everyone later, right?
Yes. Thank you very much.
Okay, good
So
night.
thank you very much, and good night. And dear guests and participants, thank you very much for joining our section today. It was nice to get in touch with you, and I hope you enjoyed this session. Whenever you have questions, please do not hesitate to contact us via our email channels, education@rivospine.com or info@rivospine.com. We offer a huge educational program with workshops here in Germany, but everywhere in the world. And one in Thailand, Bangkok, end of January. We will inform you about all that activities very soon. We hope that everyone can travel to every place in the world when this pandemic will be over, hopefully soon. And we are looking forward to see you soon. Thank you very much. Bye-bye.